Hello, welcome all of you. As today we have a session for MRCOG OSCE preparation. Dr. Abdullah, our new mentor, is with us. First, I will give you feedback on the station I have given in the group. There are six people who attempted this. I will give live feedback to all of them, and then Dr. Abdullah will continue. He will do one station with you, and he is there to guide you in many ways. Okay, so Dima, what happened with the Dima? Dima attempted very nicely. First of all, her introduction was good. Her agenda making was good. She shows empathy for the friend, history of the friend with the Down syndrome. Her information gathering was good, but she missed because told her that this is the first pregnancy. She didn't ask about the first miscarriage, so she missed that point. And actually, this is all of you. Some have done very big BBN, and some has done no BBN. Actually, if pregnancy is going in smooth way, but there is some concerning news, so you have to signpost the patient because she is already 40 years old. She has BMI of 42. Her first pregnancy was miscarriage, and this pregnancy was is a high screening result. So little bit signposting is necessary, and I told you in the end who did it very well. Okay, so she didn't signpost, she didn't do BBN, and then when she was telling about the her explanation regarding the Down syndrome was good. And then because this was my exam station, this patient is 40 years old, okay, and she lost her first pregnancy, and she don't want to take the risk. When you although high risk case will go towards the needle testing, as Dhima told, but she don't want to take the risk. So you have to tell something about the CCF, cell free DNA, fetal DNA, because it is, although a screening test, but it's 99 in 100 it is correct. So it will exclude the Down syndrome if you do it. So she didn't attach her to the support group. She didn't give next appointment with the consultant. So these are the few things. If Rima was there, we can find out more. She totally ignored her BMI 42, how to carry the pregnancy. And so she should ask about the high dose of folic acid, aspirin, and vitamin D. So these are the few points for her. Now, Ruma, your introduction was very good. Ruma, you are here?
Yes, ma'am, I'm listening.
Okay,
Yes,
if
ma'am.
you want to ask anything, you can. Okay, so
Yes, ma'am.
introduction was good. Agenda was good.
Mm-hmm.
Information gathering was very good. And you did BBN. And but I think you explained the combined test in detail. Don't need, because you already go through the combined test. So this
Ma'am, I
means.
want to ask you one thing that
Mhm.
one of the mentor, I don't remember, she told me that it's a screening test, so don't do BBN. You
Yes.
are not confirmed, so why are you doing BBN?
No, no,
She
you
told
have
me.
to, no screening test. Okay, you will not do BBN, but you will signpost her because this is a concerning news. You understand? High risk screening with the 40 years old woman with her second pregnancy, and she's very excited. What about this? So this is concerning news for her, and you are going to tell her about the needle testing. Needle testing is carries some risk,
Mm-hmm.
carries some risk of miscarriage. This
Mm-hmm.
when I will explain you, because this is my case of exam. So
Mm-hmm.
although she was para 2, but she conceived after 12 years. Her last baby was 12 years, so she was very excited. Her husband, her family, her kids very excited for. So she told me when I started, and she is high risk for this Down syndrome. So when I started telling about needle test, she told me, "No way, doctor, I cannot take the 1.1 risk for my baby, because this is the baby the whole family is welcoming, and me and my partner has been waiting for it for a long time." So So she stopped me. She doesn't want to listen a little thing. So what you will do, then you will have to give her option of self,
Okay.
and you have so just see the things. These things are concerning because they are leading to the needle testing, which carries some risk. All invasive test carries some risk. Okay,
Mm-hmm.
so you don't do full BBN, but you have to signpost that I'm going,
Okay.
and I will tell you who did very well in the last, and you all will listen to her. Okay, Rekha. Otherwise, you have done. Yes, one thing, Ruma, never give option of termination of pregnancy from the doctor should not come. Option of
Okay.
termination of pregnancy should not come from the doctor if she is not asking. If she is asking, then you have to give. But with such an exciting patient, you should not give option. Let her take, let her digest it. Let her make her decision. Okay. So
Okay.
in Down
So,
syndrome,
ma'am,
if it is a
ma'am, what
wanted,
option should I tell her about only the testing?
yes, you will tell her about the testing. If she don't want to listen the invasive testing, you have to tell about the free fetal DNA, and you have to tell it is 99 in 100, and then she will ask. Then you have to continue her pregnancy. You have to tell her about the 21-week scan. You have to tell her about the features of Down syndrome, some physical features and some congenital abnormalities like cardiac abnormalities. So you
Mm-hmm.
have to do 21 days, 21-week scan very from the fetal maternal unit. And if she has any cardiac problem or any major problem, she will be followed up there. You have to involve the MDT, and because she's obese, so you have to do a serial scan for her growth. And then you have to attach her to the some support group where she can talk to the mothers who have Down syndrome babies, and how. So at this time we cannot talk to her about how much disabilities her baby may have. So she can talk to them, so you can give her time, and you give her next appointment with the consultant. You give her this one, but don't explain her about the this one combined
Termination.
testing, termination and combined testing. Already she did combined testing, so at that time they should explain her that we will do a scan, and we will combine your age with some hormone test. So don't explain it. Okay, she already did, she gone through it.
Maybe if she say that I don't want to go for any testing, then I should
So
say
she
that
will go. No, if she
I don't.
just like my
Yeah, yeah,
patient, so we have to tell about the cell-free fetal DNA,
yeah, yeah.
because it is it carries, although we have to, although it is written in the dog article that after cell-free DNA you have to do the invasive testing also. But if she is refusing all, you just give her this one, that at least it will give more accurate resulting than this one. Okay, it has 5 times this combined testing is have 5 in 100 false result, but cell-free DNA has 1 in 100 false result. So it is more
Okay.
accurate. Okay, these two things I have to tell you. Then Rekha,
Ma'am, I didn't address the vitamin obesity also. After
yes.
that, I saw. Yeah, yeah.
Yes, you write later on. Okay, any other thing, Ruma? I think it is clear to you.
No, yeah, yeah, ma'am. But at that point, I was very much anxious that whether to continue, give the option of continuation or termination.
So this is
So,
at this time it is very
yeah, yeah,
early, because you have to
yeah, yeah,
you will just say that you take your time, you discuss with your family if you don't want to, because at that time she will guide you what she wants. If this is very precious pregnancy for you, she said no, I will not take the risk, just my patient. So I give a pause, and then I discuss about the, my decision was
yeah,
discussing
yeah.
about the certificate DNA. And then if
Mhm.
she wants to this clearly indicates that she wants to continue the pregnancy, then you take her to the pregnancy, that we will start aspirin, we will start MDT, we will do detailed scan. There are some features we can some physical features. Do you know about it? Do you want to know about this Down syndrome, or you have some idea? If she said no, I want to know, then tell her that we will do like this, and then
Mhm.
because you are obese, we will do a serial scan. Then and your delivery will not be affected by this after the delivery. You should during
Ma'am, I
pregnancy.
want to ask you one thing.
Huh?
Ma'am, it's my problem that I am very much monotonous. So, what
Yes,
should I do for it?
no problem.
Yeah, yeah.
Just take few things that just uh, uh, stand in front of the mirror and talk to yourself. Okay, when you how you will do BBN, so you change, because you people will give face to face exam, so you have to change your facial expression along with your tone will change automatically. What you want, if you have a bad news, what you want from your doctor, it should be empathetic. So you have to change your
Yeah, yeah. Same.
tone, and you have to change your facial expression. You should listen to her concerns very attentively. So these are the few things. These are not very difficult. Just if you are thinking that you are doing the same monotonous tone, so you have to work on it. It's still very, you have a lot of time. You should have 2 to 3 study partners. You should practice with them also. If there is no study partner, you should stand in front of the mirror and try to, and also you can record at this time, and you use yourself, you assess yourself that you are changing your tone or not. Okay, okay, Ruma. Hi, hello, Ruma. Anybody can listen to me?
Yes, ma'am.
Okay, okay.
Yes, we can listen to you.
Okay, so we are continuing to Rekha. Susan came or not?
Yes, ma'am.
Okay, Susan. Okay, Susan, you have done a very good. Your station was good. You did introduction agenda. Your information gathering was good. You did signposting, and this actually in whole scenario you didn't talk about the cell-free fetal DNA. Okay, because you have to talk about 1 to 2 lines in such cases. If patient is reluctant after if she is agreed for needle testing, and if she is hesitant, just tell one more screening test. If she is refusing, that keep in mind, and when you discuss with your partner, you can discuss all 3 options. Okay, so otherwise you did very well, and it was a complete station. I didn't find, only I find that you didn't talk about the cell-free fetal DNA. Okay. Otherwise, it is a good session. I have written only the negative points, good points. This means you have done very well. Okay, Susan. Good luck. Now coming to Rekha.
Yes, ma'am.
Hi, Rekha. Your introduction was good. Your agenda making was good. Your empathy was good about the previous miscarriage. Very nicely. I think you should all listen to the Rekha, how she signpost before she didn't do full BBN, but she signpost that she is going to give the some lot of information to the patient if she needs support, so she can wait. So just listen to her, these 3 2 lines. She did it very very well. I think you should all listen to, so you can make difference between the full BBN and the signposting. Okay, you nicely explained about the BMI. You take you add aspirin. You told about the serial scan. You connected to the support group. uh, in the end, when you are going, you are winding up, so you didn't give the consultant appointment, and you didn't tell her that how she would follow this. I have, Vika, I have noted. Although your station was very good, and you took the end
Actually,
of
ma'am,
the
my time finished at
ah,
that
yes, I
time.
understand. I understand. So don't talk about the labor and everything. Okay, just say one word and then complete your station, because in the end you have to give her something support group, and then give consultant appointment. So it looks nice. Otherwise, it is a good
Okay.
station. Huh? A good station, Rekha.
Thank you.
Atya is here. Atya.
Yes, I'm here.
Yes, yes.
Okay, Atya, your introduction was very good. Agenda making was good. Information gathering was good. BBN is very much extensive. That's why I'm telling, just listen to the Rekha how she did the sign posting. Okay, just all of you listen to her sign posting. Nice explanation of the Down syndrome, and you tell about. You also did. This is a blunder. If you will tell, you will tell yourself. Rumain, you did both about that. You started about the termination. What's your view about the termination? So don't give option of yourself by yourself. Let her come, because it's too early. Just let her digest this one. Give her information about the Down syndrome. Give her information about the needle testing. Give her information about the cell fetal DNA, how it works, how it can be done, and then give her time. Then you can go give attach her to the social to the support group, so where she can talk to the other mothers who have Down syndrome babies. Don't give termination. It's it doesn't look nice. Okay, so it's maybe a
Okay.
blunder, huh? Or otherwise you tell anomaly scan is very important, and you told in that we will do 21 weeks scan, detailed scan from the fetal maternal unit, and she baby may have cardiac abnormalities. Otherwise it was a good station. It was not very difficult for you, but don't if there is no lethal abnormality, you cannot. And in such case, when she has no baby at home and she is 40 years old, and first miscarriage, this age also increase the risk of miscarriages. So I think she don't want to take the risk. This is a wanted pregnancy. Otherwise, if she wants, no, I don't want to have a abnormal baby, I want to. So you can discuss termination. Okay, go with role player. Okay.
Okay. Okay.
Okay. Otherwise, you and Ruma must explain, give yourself, give option of termination. That is not good. Okay. Otherwise,
Okay.
it's good. Good one. Okay, Salma. Salma is here.
Thank you.
Salma is there. I think she's not there, but her introduction was good.
Yes,
Agent.
mom.
Ah, Salma, welcome. How are you?
Uh, Good. How are you, doctor?
Yes, you have a very uh, pretty baby voice. When you send voice note, I listen to it with a baby voice. It's a very good voice. Huh? Introduction is good. Agenda is good. Information gathering. No need for full BBN. You also did BBN. Just need signposting. So just listen to the Rekha's recording, how she did. And nice explanation of cell-free fetal DNA, nice explanation of Down syndrome. Otherwise, your station was very good. But just don't do full BBN, because it is a screening test. Still, she has a chance. Because screening test, high risk result is 5 times false positive, but cell-free fetal DNA is 1%. So what you have to do, people, that you have to go with a role player. If your role player is not happy with unwanted pregnancy and unplanned pregnancy, and she wants to go with termination, you can give. So you have to see what situation awareness is very important. What is the patient? Even in my exam, she was para 2, so I was thinking that she will go for the detailed testing, and but when she start, so I changed my path. So change your path according to the willingness of your patient. My patient was Gravida 3, Para 2. I don't know, but she told me later on that she has last delivery was 12 years back, and this pregnancy is very wanted for whole her pregnancy. So go with the role player. Now I make mm, some slides for all of you from the talk article. I think it will be helpful for you. These are the points for the station, which covers all the domains. Previous pregnancy loss, your empathy, signposting, not fulfilling, concerning news as she is 40 with history of previous pregnancy loss and now high risk for Down syndrome. Give her options of diagnostic test, proper explanation of CFF DNA as it is 9900. Give correct information. Ask her about her knowledge of Down syndrome. It is very important whether she knows about Down syndrome or not, and give proper explanation with features. Do not give option of termination of pregnancy, but respect her wishes if she wants. Support group, very important. Consultant appointment with partner, very important. Information leaflets are very important. So if you cover all these points and you okay, so these are the things. Sorry for a little bit disturbance. So these are I made for you, all of you, to complete your station. So these are slides I made from the talk article. Down syndrome is a result of an extra chromosome. However, it was only feasible to diagnose as it starts prenatally by karyotyping of the cultured amniotic fluid. Screening test in the accumulation of the subcutaneous fluid behind the fetal neck, nickel translucency that can be assessed by tomography at 11 to 13 weeks of gestation. It was seen that in trisomy pregnancy, the maternal serum concentration of beta hCG and papa is reduced as half is high. Beta hCG is twice as high, and papa is reduced to half. Okay, so that's why they make the combined test. Now, the detection rate of the first trimester combined test in twin pregnancy is similar to that in single adult pregnancy. However, here I write twin pregnancy because twin pregnancy can come as screening test. So the FPR is twice a false positive rate is twice as high in singletons because an increase in the nickel translucency in one fetus could be of twin transition syndrome or a marker of composite abnormality. In dichronic twins, an individual risk is given for each fetus, but in monochronic twins, the risk is calculated for each fetus, and an average of the two is given for the whole pregnancy. So this is important. You should know. Then cell-free DNA of maternal blood is a screening test and not a diagnostic test. Results in the form of risk assessment for trisomies. Majority reporting results for each chromosome as either low risk or high risk, more than 9. It would be preferable if patient, so it shows, it gives accurate result. It would be preferable if patient specific risks are reported, which should take into account the results from the previous scanning to previous risk of pregnancy as well as the fetal fraction, since the accuracy of cell-free DNA testing is highly dependent on the proportion of the fetal to total DNA in maternal plasma. These are the things, how the screening test work. See, false positive, maternal age, double testing, triple testing, quadruple testing, and self is 0.1. Okay, so you can give option if patient is reluctant for the needle testing or invasive testing. Now coming to the twin pregnancies, the fetal fraction used to give a successful cell-free DNA results in dichronic pregnancy should be lower fetal fraction of the two fetuses and not the total fraction. Similarly, this would, however, result in increase in the failure rate by threefold compared with a single-term pregnancy. The performance screening for trisomy twin pregnancy cannot yet be provided as the neighbors are still too small. Therefore, cell-free DNA testing can safely be offered. So, in cases, if you can say that it is better for us to do screening with the cell-free DNA in cases of twin pregnancy. The test can also be offered in dichronic pregnancy, but parents should be warned that data can accuracy and indicate. So, in monochronic pregnancy, it is better. Options for clinical implementation, it is a method for trisomies. It is a primary screen test. If that was the approach taken, then the testing maternal blood at 10 to 11 weeks would provide patients and clinician maximum information. And the cell-free data provides a high risk assessment for trisomies. Then the option of chorionic plus sampling at 12 weeks is still feasible versus opting for amniocentesis at a later gestation. On the other hand, if the cell-free DNA results provide it was low risk for trisomy, then the parents can be reassured that it is very unlikely that the fetus is affected. Okay. Now it is available in the and this is combined screening at 11 to 13 weeks. It is high risk, more than one is 1/10 of invasive pregnancy. Can anyone this one hold the mic because my voice is okay. So this is very important. If it is low risk, nothing to be else. If high risk, we have to go for invasive testing. Individual test, you have to do CFF-DNA, and if it is negative, nothing to do. If it is positive, then invasive testing. But if it high risk and patient is reluctant to this one, you can go for this, just like my patient. Okay. Thank you for attending my half session. Thank you, all of you. If you have any queries, you can ask me. Then I will hand it over to Dr. Abdullah. Anyone wants to ask any question regarding this station or anything?
No, ma'am. Thank you so much.
Okay, thank you for joining. Okay, Dr. Abdullah, you are here. Hello, Dr. Abdullah. Dr. Abdullah is here. Hello, Dr. Abdullah. Dr. Abdullah. Where is he? Girls, please be active and take part. We have long course, we have fast track, and we are also booking for the mock and the face-to-face circuit. So if you have any interest, you can ask me or any of the mentors in our group. Okay. Hello, it is Dr. Abdullah. Hello, Dr. Abdullah. Girls, just wait. As soon as Dr. Abdullah is available, he will take over. By the time, if you want to ask me something, Dr. Huma is also here. I am also here. So you can ask me. Yes, Nazneen is asking. Nazneen, you are not in our group, in our free group, MRCOG OSCE preparation. We have full information there. And also we have Facebook page, and also we have three groups we are running. We have our MRCPI OSCE group, we have our MRCOG part 2 group, and we have MRCOG part 3 group. Yes, Dr. Abdullah.
Hello guys, can you hear me?
Yes, we can hear you. Welcome.
Yeah, sorry
No
for
problem.
the all missed today. The technology has a problem.
No problem, no problem. It is part of the game. The best thing is that you are here, and I will make you host. Abdullah is here, okay, and you will check. Make host. I make you host. Okay, you check. You are host
Uh,
now, so you can share your. You are
yeah.
host.
Actually, also, like others, I can join from my other device. So I ask Zubia to put the slides. That is okay.
Okay, so you cannot put slides. So Zubia will put slides. So
Zubia will put the slide
so
for me. Yeah.
so
Because
Zubia will be the host. I have to change again, or you
yeah,
have no.
Put Zubia because I can log in from the mobile, but I can't log from the
Okay,
iPad.
Abdullah, just listen to me. Now you are the host. You have to go to the Zubia in the participant group, and there are three dots. You put your cursor on the dots. It will came host, make host. So you make Zubia host. I cannot do now because you are the host now.
Mm.
You go in the part.
Dr. Abdullah,
Yes.
Dr. Abdullah, I'm from my mobile, so I think I cannot share your slides as well, right? As I messaged you. I think send your file to Dr. Fauzia then.
Okay, I can
Better.
send it to Dr. Fauzia.
Okay.
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 Yeah, but Fauzia, maybe she want to go early then, or
No problem, but you have to make me host again. You have to go in the participant. There are three dots.
yeah.
Put your cursor on the on three dots. There is option came make host. So make me host again, and then send the slide on the Telegram or wherever you want, or you can send me. I will send you my email. You can send me there. Just hold.
I can send it to your Telegram. You can send it to the Telegram.
Okay.
अब ठीक है न्यूसी
You're fine.
this one
So, how can in Fauzia, you are not host now? Fauzia, can you hear me?
Yes, I can hear you, Abdullah.
Yeah, you are a host now.
I will check. No, because still I am seeing your this one.
And Zubia cannot be a host, no?
Because Mafi Faida, no use. She is also on mobile, so she cannot share your
Ah, she's
screen.
in a mobile.
I am on laptop, so you have to
So,
make me host again.
yeah, I put this participant, this three here, and ask to unmute.
No, in front of my name there are three dots. In front of my name there are three dots. You have to press these three dots and then make me host.
Yeah. I think I make
Yes,
you do now.
yes. I am the host now.
Okay. Okay.
Okay, no problem. Share a screen. I will come to my screen again. Okay, it is finished. Now I will try to. Okay. You send me your this one. Sorry,
I send it to you.
dear
I send it.
participant.
Did
Okay,
you find it?
I will check. No, still not. In my Telegram, where you send?
In Telegram. Yeah. 1 second again. Zubia, if you can send it to Fauzia in the Telegram.
Okay, I'm sending. Okay.
Yeah. Sorry, we'll just try to avoid this next time.
No, it's okay. It's okay. It's part of the game. We are all new in this.
Yeah,
and we-
because my other device at home and I'm at hospital now. So
Oh, you have long duties.
no, just I went there because it is quiet there. Escaping from home.
Yes, this is the.
On Saturday, nobody in the hospital. Very few people are there.
That's right. Okay, that's good.
I think some people also they found some difficulty in login today.
I don't know what. Just I disabled the waiting room. Then after this one, Dr. Umar told me to disable the waiting room. So I disabled the waiting room. Then after that, people can join this one, the session. I also don't know very much, many things about these things. So okay, so sent or not? Okay, you shared. Just to take some time.
Did you get it, Fawzia?
Yes, I get it.
Okay.
Okay, I have to go for the Telegram. Okay, I will start sharing. Dr. Abdullah, you can speak. You can see enhanced recovery. You can see
No.
on.
Yes, yeah, I can, yeah.
And this is your introduction, I know. Yes, you start with your introduction.
Okay, so yeah, I met most of you before. Dr. Abdullah, just to recap, I'm working in Ireland for the last 5 years as Obs and Gynae. I got my MRCPI in 2017 and the MRCOE recently. So today I will do one station with you because half of the session will be just general questions, general advice about the exam. And if people want to ask some question about Ireland and how to get a consultant job, how the chances for fellowship, and anything regarding this. And from next week, hopefully, we'll do 2 sessions. So today I will do structured discussion. Maybe next week I can do teaching. The week after, simulated patient task, and the last one will be simulated patient task with the examiner. So we can get each week some tips about approach for each type of questions. So we can start with structured discussion. This station is came to my exam actually, so I remember it very, very well. All the questions and what the marks mostly given in what aspect, and after that because the examiner, I remember I finished the session in 7 minutes, and after that start to chat with me outside the scope, and he just asked me where do you work and this and this and this, and I tried to say that no, I want to say something, maybe I forgot something. He told me no, you got the full mark. So how is your previous stations? And after that I start just to chat, and this is a good chance that to get relaxed to go to the next station. Although this not happen many times in MRCOG, but it happened in MRCPI.
Okay,
Uh,
you can see how can you define enhanced recovery program?
Yeah. So the first question, I think Fatima is going to do. Fatima Muhammad, she asked me earlier to.
Yes, Dr. Abdullah, I can do.
Yeah. So, okay, Fatima, you can start.
You just give me 1 second. I'm going upstairs. I'm hiding from my son. Just give me 1 second.
I'm starting, when she will start, I will start 10 minutes time, okay?
So this station, I think she came in Abu Dhabi exam the second day, and before that it came only once or twice, I think, the recall. So it is not very common recall. So that the college will have a tendency to bring it many times because it's considered like a new station. So it's about enhanced recovery for cesarean section. So people have not to confuse it with enhanced recovery for a gynae cases. Okay. So the first
Dr.
question.
Abdullah, I'm ready.
Yeah. Okay, Fatima. So the first question is we start with the 10 minutes now. How
Yes,
can you define enhanced recovery for cesarean section?
तो मुंह मीठा
भूख लगी है
कुछ खा उनमें वो भी खा दही फुल्की भी खा दही में
Please mute all of you.
Dr. Fatima, you are ready? Other people, can you hear me?
Yes, Dr. Abdullah, we can hear you. I think Fatma is lost somewhere.
So, Dr. Roma, she asked me before also to present if Fatima is not ready.
Okay, Dr. Abdullah, we can choose someone else who wants to present
Yeah,
with Dr.
Dr.
Abdullah, because I think Dr. Fatma is lost. Maybe her connection is
Where is
lost.
Dr. Roma? Are you online?
Sir, my
Dr.
internet
Roma?
is not good. I'm going and coming. It's not good today.
Hello.
Hello.
Yeah, Dr. Abdullah, I'm really sorry I lost my connection, but I'm back now. If someone is doing, or I should start.
You can start.
Okay. So, enhanced recovery, which was launched basically to take further certain steps to increase the recovery during the cesarean section. and then to make the patient's recovery hasten, and so that patient can return to its daily activities, and also it help to reduce to minimize the intra-op and post-operative complications as well.
Okay. Second question.
Yes.
Second question, Zubia. What is the benefit of enhanced
No.
recovery?
The benefits of the enhanced recovery program are that the patient return to its normal life earlier. It helps to reduce complications. It also
Hello.
hello. Someone
Yes.
mute me. So it also helps to reduce the
Fatma?
cost to the
Fatma,
hospital.
sorry, behind you
And
there is so much of the noise. I think your kids are speaking. So can you go to some other place, or TV is open? So we cannot hear you properly. So Fatma, please go away from the noises behind you.
okay. Okay, ma'am. Okay. This happened all the time. Yes, ma'am. This happened.
Your voice is interrupted, Fatima.
Yes, we cannot hear you properly. Dear girls, when you are presenting, please make sure that nobody is around you for 10 minutes at least, because it was so much noisy. We cannot hear properly, and we cannot record it properly.
Fauzia, you cannot bring the other slide?
Okay. Okay, that will give you.
Dr. Abdullah, can you see the 4 questions?
No, I only see the first one.
Ah, how come? Okay, I
Can
will
you go? Yeah, go for the.
new share. I will go for the new share.
That will give you.
Yes.
Ma-
Yeah. Yeah.
You
And
can
just maximize the screen. Maximize the screen. Yeah.
Okay, okay. Now it is going down.
Yeah. We are in the second question now. Yeah.
Hmm. Now you can see 4 questions.
Yes, I can see. Yeah. But where is Fatima?
I think she.
I'm here, ma'am. I'm here.
Khalas,
So-
start.
But
Okay,
but
just continue on the second question. What is the benefit? What are the benefits of enhanced recovery?
the benefits of enhanced recoveries are towards the patient as well as towards the
Okay.
hospital. Regarding the
One more.
patients are able to are included in their in their medical care. So and they can return to their normal activities earlier by if patients are followed by enhanced recovery program post-operatively. The post-operative complications can be minimized by following the enhanced recovery program. And regarding the hospital, there is less burden on the hospital staff, as well as there is a less cost due to by following this enhanced recovery program. So by following the enhanced recovery program, all the patients can gain the universal care from the health professionals. Yeah.
Okay, good. So, what is the criteria, the inclusion and the exclusion criteria for enhanced recovery?
The inclusion criteria of the enhanced recovery is that basically this program,
Some
this is
unmute.
first
Some people are unmute. Yes, continue, Fatima. Sorry.
Sorry, Dr. Abdullah, I'm really sorry. You can't imagine my situation. So the inclusion criteria of enhanced recovery program this program was basically started for the major major surgeries like gynecological, urological, and orthopedic surgeries. However, seeing its benefits, so now it is enhanced recovery program is involved in most of the surgical units. The inclusion criteria is that it is started from basically the community care. GP and other community healthcare should be involved in the enhanced recovery program. So the patient should be there should be shared decision making between the patient and the healthcare professionals. The patient if patient has any comorbidities like medical comorbidities, diabetes, hypertension, or any other comorbidity, it should be treated in the primary care, and by optimizing patient health, then patient should be referred to the secondary care for further management. And before going on a surgery, the patient should be the discharge date, and what will happen, what will be the surgical steps, how patient will be recovered. It should all be included in the discussion.
Yeah.
And
Okay. So take me through the pre-operative component briefly.
yeah, the pre-operative component is that patient should ideally be operated as a daycare surgery, and the long preparatory gut preparatory hours and long NPO should be avoided. Patient and it depends on the surgery, so it should be the NPO should be at least 4 hours for the solids, and for the liquid it can be just 1 hour precautions. And after the patient hemoglobin and all the comorbidities should be optimized before surgery. And if there should be no or at all gut preparation. Starvation should be kept minimized, and patient should be started with a fluid if it is needed, if surgery is prolonged before surgery. And
Anything else you want to add in the pre-operative?
the pre-operative.
Just imagine that you are in the hospital and you have a cesarean section this morning. Any important aspect you forget?
Any? Sorry, Dr. Abdullah.
Okay, no problem. So speak about the intraoperative elements.
In the intraoperative elements, anesthesia should be regional anesthesia. However, it depends on the patient surgery, type of the surgery and surgical time. However, the regional and epidural should be preferred. Patient should adequate fluid should be given. Hypothermia should be avoided, and incision should be lower transfers incision. And there should be every effort should be made to like no drain should be there, and adequate hemostasis should be secured. And regarding the closing, the skin should be closed by subcuticular incisions, subcuticular stitches.
So what's the name of the lower transverse incision?
What is the name of lower transverse skin incision?
Any name, any other name for this cesarean section incision? What we call it? Is it Phanestrel or Joel Cohen?
Phanestrel. Most commonly it is Phanestrel.
And did you hear about Joel Cohen incision?
Yes, I heard.
Which one is best nowadays?
The most common use incision is Phanestrel. However, both have its advantages and disadvantages. So I'm not working in UK, so I don't have any idea like which one is popular nowadays.
No problem. Okay. So last question: what is the postoperative component of the enhanced recovery for cesarean section?
In the post-operatively, the patient vitals intake output should be monitored on the Mayo chart. The opioids analgesia should be avoided. And early mobilization should be done. Early catheter and drain should be removed if drain are there. And early, if patient is has been past colitis or bowel sounds are audible, or patient is then early break of NPO should be done. Patient should be encouraged early mobilization. So to reduce the risk of DVT. And once patient is ready to discharge, the further follow-up with red flag signs should be discussed with the patient. Patient primary care should be informed regarding the follow-up, and the follow-up date should be discussed with the patient. And
Okay.
antibiotic cover should be given according to the hospital protocols.
Okay. Anything you want to add in any of the questions above?
Dr. Abdullah, there are so many things. Actually, I didn't read this session. So I was just
You did
trying.
well. You did very well. Only just I will comment on how to improve yourself more. But you did very well. Yeah.
I didn't organize my.
And this exam it need a good memory, because you can't cover all the session in the last 2 or 3 weeks. So you need really to scratch your memory very hard, because a lot of station you will go in the exam and you will remember that you studied long time ago. So it really depends on your
Dr. Abdullah,
memory. Yeah.
actually, really speaking, I want to share my experience. I appeared in UK exam this November and I failed. Yeah, on 60%. So the thing is that I'm
You
really
will
bad
do
in
it.
Ratka.
No,
I'm
you will
really
do it
bad in
this
Ratka.
time.
Please tell me something that how I should remember structured
Yeah.
discussion. Tuck, 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 tuck. I don't know.
Okay. Yeah. You remember most of the important. Only for the structured discussion, for me, usually I give advice that people they have to be a bit fast, because when you finish the question before the time, first of all you will give the examiner a chance to interrupt. So in the structured discussion, when the examiner asks you something inside the question or interrupt you, for example, I tell you what is the difference, is there is a name for this incision. So this comment for the examiner, you have to take it and try to get the information for that, because they usually carry marks.
Yes.
You know, he want to give you more marks, or he want to help you, the examiner. So if you are done, just try not to consume all the 10 minutes. In the benefit, you spoke a lot, because sometimes you speak and this answer will be for the next question. So don't do like that. Just speak briefly. After that, if you finish early, the examiner will take you again to the first question, second question. And sometimes the examiner also they forget, by the way. Sometimes the examiners they forget that you mentioned something. So if you mention it again, definitely you will get the mark. So my advice for you just to be fast and to answer the question fast. So, and when the examiner asks you for something, just try to get the answer. Okay. So for the definition, they want to hear something. You didn't mention the word multidisciplinary. So the word multidisciplinary is very important, because enhanced recovery is a multidisciplinary standardized approach to improve the care of surgical patient from preoperative through the surgery and postoperative. So no need just how can I keep all this definition? It is a long definition. No, it is not. Just you need to include the word multidisciplinary, and you need to include the word pre-op, intra-op, and post-op. After this, whatever you mention is okay. Just he need to listen to this word, you know. So it is a multidisciplinary approach, improving the care of surgical patient for the pre-operative through the surgery and the post-operative. The second question was, what's the benefit or the aim of the enhanced recovery? So you did mention the hospital cost, which is very good. You did mention about the hospital stay, to reduce the hospital stay, and it decreases the complication rate, but you didn't mention the satisfaction. The patient satisfaction is very important.
Yeah, it's very
Okay.
important.
Yeah. So this is just a lot of details inside. You can just grab this. You can go, Fauzia, for the next page. This diagram. Yeah, this summarize all the pre-op from home, from primary care to intra-op, post-op until the discharge. Okay. So what is the inclusion criteria and the exclusion criteria? Inclusion criteria is uncomplicated elective cesarean section. And the exclusion criteria, this question is also has a lot of marks. This question you have to remember. So it is patient who have comorbidities. If patient has any comorbidities, any heart disease or any chronic illnesses or something like that. Complicated if the patient is planned for enhanced recovery, but after that intraoperative or postoperative complication has happened. Patient put in general anesthesia, bladder injury, adhesions, estimated blood loss more than a liter, ended by hysterectomy, significant delay in starting surgery, uncomplicated, uncontrolled pain, urine retention, postoperative ileus infection. Any complication arise will not make the patient very suitable for enhanced recovery. After that, we come to the pre-op, intra-op, and post-op. So for the pre-operative, we need to optimize the medical condition if the patient is hypertensive or preeclampsia or chronic, mainly chronic, if diabetes, hemoglobin, you mentioned about that, to optimize hemoglobin, to optimize body mass index, patient education about the risk of cesarean section or maternal request, smoking cessation, illicit drug misuse, expectation for surgery, intra and post-operative. This is very important also to discuss with the patient what is expected inside and after the operation, and explain about the breastfeeding physiology as well. So the light diet or the light meal may be consumed up to 6 hours before the surgery, and patient encouraged to consume clear fluid until 2 hours before surgery. The one oral and mechanical bowel preparation is discouraged. You mentioned about that, which is good. But the last one you forget completely. I tried to prompt you, but you couldn't remember.
Yeah, pre-op
The
medication.
pre-medication, anti-acid, antihistamine receptor blocker is very important. Although it is not routinely given for spinal, but for the general, it reduces the risk of aspiration. For the intraoperative elements, antibiotic prophylaxis, ideally before the skin incision. I remember in my exam, the examiner asked me if you have a Cat1 cesarean section or something like that, the patient is put before for enhanced recovery, and after that she went for emergency section. How you can give the antibiotic? So yes, you mentioned that it is as soon as possible, and the cephalosporin is a preferred choice. Use of antiseptic chlorhexidine for skin cleaning. Vaginal cleaning before cesarean section may reduce the rate of endometritis and postoperative fever, but it will not reduce the risk of wound infection. So limiting also IV fluid to less than 3 liter for routine cases, and manage the spinal anesthesia associated hypotension with vasopressor. Prevention of hypothermia using forced air warming or warm fluid, and increase the temperature of operating room to more than 72 degrees Fahrenheit. And neuraxial anesthesia, spinal or combined spinal epidural is the preferred. This is the one, number 7. This is Fatima's question I asked you. Coagulal incision associated with shorter operation time and less morbidity. So the difference between the Phenasteel, in the past people used Phenasteel, which is lower than the Joe Cohen incision by 3 centimeter. The difference is that it is smiling. The Phenasteel is smiling, but the Joe Cohen is straight. The benefit of Phenasteel over the Joe Cohen that it is more cosmetic, but the Joe Cohen incision is the preferred one nowadays. Blunt extension of uterine incision, avoid uterine externalization, use of lowest effective use of oxytocin and uterotonic will decrease the drug-related nausea and vomiting. Spontaneous delivery of the placenta and gentle massage of the uterus plus control contraction rather than manual removal of the placenta, because it's associated with more risk of endometritis and increased blood loss. Non-closure of the peritoneum, and reapproximation of subcutaneous fat, it is more than 2 centimeters, and skin-to-skin contact should be facilitated soon after delivery. So sometimes you find it hard to remember 14 point, but if you mention the most important one and the most practical one, yeah, the examiner will give you a good mark. So for the postoperative element, minimizing the postoperative opioid use because it decreases the risk of ILS and promote return of power function. Assumption of regular diet within 2 to 4 hours of surgery. Water can be drunk after 1 hour only. Glycemic control less than 200 milligram per deciliter, and early mobilization soon after return of motor function decrease the risk of muscle atrophy, hypoxia, postoperative VET, and insulin resistance. VET assessment after delivery, of course. Hemoglobin assessment to be considered for those who lost blood intraoperative or postoperative as anemia associated with delayed recovery and postoperative depression. So if the patient lost very little blood and her initial hemoglobin before delivery was good, so no need to check the hemoglobin. Removal of urinary catheter after 6 to 12 hours. And no removal after 6 p.m. Yeah, if so, the patient has a section in the morning, and the 12 hours will be after 6 p.m. So you leave it till next morning. I remember he asked me this question as well. Start breastfeeding as soon as possible with the skin-to-skin contact. So this is a very busy slide, but most of you can't mention all of these stations. Still, maybe I didn't mention something. But if you mention the one which I said here, you will get a good mark for the station.
Okay, thank you, Dr. Abdullah. It was a really
Thank
good
you.
presentation. Actually, truly speaking, what I want to say, I was not thinking about specifically C-section. That's why I miss so many points.
You are okay. Just get this information here in this presentation, and you will be fine. Don't worry. So just for the structured discussion, just as I mentioned, I feel it is one of the easiest. It is maybe the teaching and the station is more easier than the simulated patient task and the lay examiner station. So try just not to lose any marks for this kind of station of teaching. Anyone has any question before to go to speak about? Yeah.
Dr. Abdullah, one thing I want to say, in this exam, November, there was one station, it was bridging thromboprophylaxis. So outside the cubicle, it was written that inside there is ST1, and she is new and she wants to know more about the bridging thromboprophylaxis. You have hospital protocol per pharma. So adverse concerns or like all these domains were mentioned. So when I entered inside, there was nobody except the examiner. So I start session as a teaching. I greet her. I asked her the purpose of the teaching. Like, is any other concern? What she want? What is her concern? What she want? And I rule out bullying as well. How the things are going in department. But the examiner said she didn't answer me well, and she said, "Why you are asking this? Just start your station." So what should I was confused that outside it is a teaching station, but inside it is a like she's saying, why you are asking all these questions? Just start your station. So what should we
Yes.
do? Like,
Okay. So I will speak about the teaching maybe next time because today just for structured discussion. But in general, for the teaching, maybe the examiner during the exam you will find different kind of examiner. Some of them they are examiner for last 30 years, and they will get very bored with the repetition. So they need just you to go for that. But maybe you ask also for the bullying many times, so you need just to ask once and a decent question, maybe something like that. But this maybe depends on the examiner, him or herself. But you have to follow the template, and even
yeah,
that if the
I
examiner
followed the
told you,
template.
if
So
the
this was the
examiner
problem.
ask you just to go, that is okay. Maybe he will not deduct you from the question which you meet, because you are trying to follow the template to get the mark.
Template.
So if the examiner asks you to bypass this, So that means he will not detect mark from this. Just he need you to go for teaching. So don't worry if the examiner asks you to go straight away.
This was my first
Can I
session. I
interrupt,
was so
Dr. Abdullah?
confused.
Yes, can I speak regarding your query, Doctor? The same scenario. I'm Dr. Zubia, first of all, one of the mentors of MRCOG OSCE Prep. The same kind of scenario came in my exam as well, and I gave the exam as online. And it was the same bridging thromboprophylaxis, and only the examiner was sitting in front of me, and there was no, the colleague. So we need to behave like that. We are talking to the colleague, and the same way I followed the template, like ruling out the bullying and everything. And she was expressing the same way, like she was like face was masked, and she was not telling me anything. That I asked that, are you happy in the department and everything, but she did not reply. Then I carried out with my similar like template of teaching, like starting with the explaining the bridging thromboprophylaxis, the definition and everything. But sometimes I just want to add this, that sometimes it happens, it depends on the mood of the examiner, or maybe
Yeah.
they are tired of listening the same kind of things from all the candidates. So it's okay. When it happens in the exam, just go with the template that you are following for the teaching, because it's important for us to rule out bullying, right?
Yeah.
So just
Yeah, ma'am,
follow your
actually,
template.
I got confused because this was my the first station. And, so I was thinking maybe I did something wrong, that she is pulling faces and she is not happy with me. So,
Yes, I can understand. I totally can understand, because in my exam as well, this happened, and I was suspecting the same, that this station is bullying. 2 or 3 times in between, even it came in my mind that I'm going on the wrong side, or what is going on. It makes us confused when the examiner is very mass face and
yeah,
not replying
exactly.
very properly. So we think that maybe it is a bullying station or what. But in the end, I came to know, like after this exam finishes, and I discussed with my friends, that it was not the bullying and it was the bridging, and it happened to many candidates. Like she behaved like this, so it's okay. It happens. You just follow your template, rule out the bullying, do whatever like you were doing as a general, and don't be confused, don't be panicked because of all these behaviors. So it
Yeah,
happens, it's
thank you,
normal.
Dr. Zubia.
Thank you.
Yes, it happens. Even for the labor orbitalization, sometimes also they don't want you to introduce and do that. And I will assign my team for the according to priority. He will just ask you. He will point to the paper in front of him, or he ask you just to go through. So don't worry about this different behavior of examiners.
Yeah, Dr. Abdullah, inshallah. Now I have
Yeah,
gone through all
inshallah,
these.
inshallah. This exam only you need just to be organized, to be relaxed. So even for the different kind of stations, so just you need to make a good environment inside the cubicle. So just you need to make the role player. I will speak about this later on, about when we speak about simulated patient task and this. But this exam, don't worry, it is not a knowledge at all. It is just how you convince the patient, how you make the patient happy, how you are just touching the safety point and this. So practice and get a good feedback. We have good mentors in this group. Just keep recording, send the recording, and also I will try to contribute in the feedback in the coming time. And you will be okay. All of you will pass, inshallah.
Inshallah, Dr. Abdullah. Thank you so much.
Inshallah. Anyone else who want to say anything?